Hi, Dr. Paul here. I want to talk about a condition that I treat a lot. It's a more complex than other conditions I treat. It's called bipolar disorder. I'm sure you've heard of it. It's a difficult one to describe because there's a lot of different characteristics, a lot of stuff going on here. It's definitely more complex than the typical depression, anxiety patients. So bipolar means, kind of people think about up and down. But a statistic that's really shocking, and I talk about this in my book, probably the most shocking statistic that in my book is that it takes about 7 to 10 years and 3 to 4 doctors to adequately to diagnose bipolar disorder. So think about that. Why does it take so long to figure it out? Well, because doctors are looking in the wrong direction. So when people think bipolar disorder, people think about mania. So mania is when people feel like kind of psychotic and they're irrational and they're paranoid and they maybe sometimes hear voices. That's probably really more schizophrenia, but paranoia meaning think that people are watching them, listening to them. So they do odd behaviors. So bipolar 1 disorder is when you have mania, but that's only 10% of bipolar disorder. Bipolar 2 disorder, which is 20%, is not the level of mania we call hypomania. So hypomania, you don't get the irrationality and the paranoia. And the other thing in bipolar 1, by the way, is like, spending too much money, hypersexual, making really poor decisions, speeding. So that's, again, the more the mania. Hypomania, again, is lesser, but hypomanic people are still rapid pace. They talk rapidly, and they don't need much sleep. They can get by with 3-4 hours sleep and they're good to go. But they're very rapid in how they do things and talking and actions. And the problem with that and with bipolar 1 is that it doesn't last. People like the hypomania because they're very productive. Very creative, but then what happens is they kind of crash into depression eventually, and then they want to get back to where they were. So really, with hypomania and with mania, usually you're going to see a depression, and so 70% of bipolar disorder is what I call bipolar spectrum, which means that it's not any of those things. So what is it? Well, it's more of a depression that's tougher to treat, and that maybe doesn't respond to the typical medications I use for depression, like SSRIs, SNRIs, Wellbutrin. So the typical antidepressants I use for depression, or we call unipolar depression, may get them somewhat better if they tolerate them, but don't get them fully better. And so that's how I can tell that there's something else going on. If it's a subtle case, where then sometimes I will start with antidepressants. But if the antidepressants either get them only so much better, and then that's it, and normally if it was depression, it would be a lot easier. Then I know there's something else going on, and that's why I start really exploring the bipolar realm. And we have to then use the different types of medications. Or sometimes really anxiety that's not getting better with the typical medications that we use. So again, so most doctors miss it because most doctors are looking for the mania or the hypomania, or maybe the hypomania. They might miss that, but they'll see the mania, but they don't think about the depression. So that's why it takes a lot of doctors a lot of time, or they misdiagnose it, they underdiagnose it. But it's very common that happens, and that's why it takes a long time for a lot of people to get diagnosed and treated properly. And the problem there is that's a lot of years in time. Some people may not last that long. Some people may drop out of treatment. People may get frustrated because the medications aren't working. Or why are the antidepressants making me worse? And they're supposed to be making me better. So they get frustrated, and some of them, unfortunately, probably drop out of treatment, and they're not treated after that, which is sad to me because these are people that could be helped, but unfortunately they got turned off because they went to a doctor who didn't understand it and didn't treat it properly, or maybe didn't communicate with them that, hey, if this doesn't work, we got to try this. But you got to be, doctors have to communicate properly with patients to make sure they understand that this is a process to figure out. It's not always easy. Now, if someone comes to me and they come in with mania or hypomania, well, that's more obvious. And then so as far as treatment of the condition, it depends on the situation. It depends on where they're at. Are they in a depression? Then I will typically start with antidepressants. Are they manic? Then I probably won't do that because an antidepressant in that case might make them worse. So in that case, I'll put them on, we call a mood stabilizer, which is the most common ones I use are the antipsychotic medications. And there's also lithium you might have heard of, and Depakote, which are the more we call classic mood stabilizers. I don't use as much of those, maybe in tougher cases. But I like to use the other class. So let me explain how these medications work. So again, with antidepressants, typically the classic ones, because with bipolar disorder, often it's a combination of the typical antidepressants with a mood stabilizer. That's what I commonly will do with most patients. Now, if it's a bipolar 1 patient, and a lot of them don't have any depression, so if that's the case, no antidepressants for that person. All they need is mood stabilizers. So we'll talk about that. So bipolar, well, let me talk about the depression first. So with depression, usually it has to do with serotonin. So as you know, as I've said in other videos, we're talking about chemicals that are constantly moving from one cell to the next cell on a constant basis. They're constantly moving. And when you look at the details here, there's typically, a lot of times with depression, there's an issue with serotonin, norepinephrine, sometimes dopamine. So sometimes, I will give an SNRI, like medication that works for serotonin, norepinephrine. But, let's say I give him that and they get worse. Okay, take that away. That's not it. So if that would make him worse, then I know it's a bipolar patient, okay? Let's say it makes them better, but somewhat better. Okay, that's fine. So let's say I add Wellbutrin, which is a common thing I do with depression, and let's say they get better. Let's say those work, but they're not fully better. And let's say they're not even manic. They're just not, the depression's not better. Okay, well, then I have to explore. I might think about Lamictal, which is a good medication that works on GABA, which is another chemical that I address. And then sometimes when you balance GABA with something like Lamictal, then when that starts moving correctly, then that can resolve the depression. The other things I use, the antipsychotics work also on dopamine, like Wellbutrin does, but they work more on actually slowing dopamine down. So sometimes when you feel better with Wellbutrin because it's helping the depression, but then what's happening is dopamine's going too fast. And so basically is what the antipsychotics do is they attach and they kind of slow it down. So it becomes like a balancing act because without that dopamine, we call it dopamine antagonist, the antipsychotic, then things are going to go too fast. If we only give the antipsychotic, it slows down dopamine. But if we take the Wellbutrin away, then sometimes they get depressed and they're tired and they're unmotivated. So sometimes when you put them together, and then you have to fine tune the dosing properly so they're on the exactly right doses, which takes a little bit of time to figure that out. So then this can be really effective treatment. And so it's really figured out, along the way. With typical depression and anxiety, I might figure that out really quickly within a visit or two, maybe 3 at the outside. With bipolar patients, it might take more time. It might take not only maybe 2 to 3, but maybe a few 2 or 3 more, sometimes more visits to kind of fine tune everything, because it sometimes takes a combination of the things, 3 medications, sometimes 4, sometimes more, to get this just right. But yeah, we have to it has to do with taking a really good history, trying to figure out what type of bipolar is it. Is it a very mild, subtle bipolar disorder? Then that's a little bit easier to treat. Some of the agents I use, the common one I use is called Rexulti. There's Vraylar. You're going to see those commercials out there, Caplyta. There's a lot of different ones that are out new now, and again, we say antipsychotic, these are for patients. Sometimes they have no psychosis, so it's kind of a mislabel for some people because it's confusing. Because people think, oh, I'm not psychotic, I'm just depressed. Well, yeah, but you have a depression that's not as easy to treat as with just antidepressants. So that takes us sometimes to explain to patients that don't worry about the labels of the medication. That's not about the labels. It's about getting you healthy. And so when we get this proper balance, it's a really satisfying. I love treating bipolar disorder because it's more challenging. I love the challenge. I love figuring out the puzzle. Now you want to throw another wrinkle in is if someone has ADD in bipolar, that's even trickier. So what I do is typically try to balance things first, but then if they have ADD, they're going to have problems with focusing. So sometimes after I've already fixed the problem here, then I put a stimulant in there, and then that'll get things moving better. But you got to be careful with that. You can't go do too much, or sometimes if you do, it helps the ADD, but the other gets worse. I have to change the dose of that. So it's a little bit tricky. But I've been doing this a long time. I'm really good at it, and I know I'm being very humble here. But you have to have experience with this because you have to know what to do when, but the trickiness and the puzzle part of it is really what I enjoy. Because it's so satisfying to see, because some of these people have been suffering a long time. Some of these people have seen a boatload of doctors that haven't figured them out. And I love being the doctor that comes in, saves the day, figures out the problem, gets them better finally, and gives them the help that they need. And these are very happy patients that when they're stable, when they haven't been for many, many years, some of them, if ever, many of them have felt this way most of their lives. And so when I get people functioning, and because they can't help it, you can't help what's going on here because what causes this, genetics, runs in your family. And it may not be easy to trace that because there could be alcoholism, there could be severe depression where you don't think it's bipolar, but it probably is. And so the family history may be tricky to figure it out. Sometimes it's easy, but again, you see addiction, you see dysfunction, you see, so you can kind of figure it out that it's usually a stronger family history than someone with an easier to treat type of depression. So that's what I love it because it's because of that really dire statistic. I like to be someone who, it doesn't take years, it takes a month or a couple weeks or a month or maybe 2 months to figure it out. That's as long as it should take. If it's taking longer than that, then it's just not being done right. And so anyway, I hope this helps. I know it's a little bit complex, but this is a condition that is... It's complex, but it's doable. It's treatable. And I talk about this in my books. I have a chapter in my first book on. It's called the Ups and Downs of Bipolar Disorder. If you wanted to get that, that's the first of my 3-book series, Healing the Mind and Body, the trilogy. I have a chapter in my new book, The Corona Protocol. My chapter 3 is on bipolar disorder, and I tell 2 stories about people that have different conditions. So the first story is a person that has more of like a bipolar 1, more of a severe bipolar. The second story is a guy who has bipolar depression. So I kind of do that purposely to show there's more severe, there's more subtle, so that way it's more understandable.